rather than going to get started because I have a lot to cover and I tell a lot of stories and I'm Southern, so I don't talk real fast. So we will go ahead and get started. So next and next. Okay. Everybody says she has or he has dementia. We just commonly call it that regardless, that somebody has dementia. Dementia is not a disease. Dementia is a symptom. So like if you have a runny nose with a cold, the runny nose is a symptom of the cold. Same with dementia. Dementia is a symptom of another disease. So, next slide. These are some of the primary causes for dementia. Alzheimer's is about 70% of most of the dementias that we see in the United States, most prevalent, but there are many other disease processes that have the symptom of dementia associated with them. And we're going to talk about those for just a minute, but we're going to spend the morning talking about Alzheimer's primarily. So we'll come back to Alzheimer's, and the thing to remember with Alzheimer's is that when a person is diagnosed with Alzheimer's, Alzheimer's is a progressively linear disease. So it has very defined stages, very defined symptoms that go along with it. These others do not, and that's kind of what differentiates Alzheimer's from the other types of dementia. So if you look at vascular dementia is just as it says. There have been blood clots or brain bleeds in the brain and because you don't know where that's going to happen, there is no linear progress or process to the dementia. It can be whatever is happening in the brain. Sometimes it doesn't affect memory at all. Sometimes it doesn't cause dementia, it just causes physical limitations. But for the most part, it's just reliant on where did that blood clot or brain bleed occur in the brain. Lewy body dementia is related specifically to Parkinson's disease. So if a person has Parkinson's disease and they develop a dementia within a couple of years of that diagnosis, it pretty much is related to the Parkinson's. Now, what happens with with Lewy body? Lewy body is actually a protein. So this particular protein, this Lewy body protein, it accumulates in the brain in different areas and it causes a person to have dementia. So the first thing you're going to see with an Alzheimer's patient is memory involvement. The first thing you're going to see with a Lewy bodies patient is motor involvement. So the motor involvement is the first one to be affected, whereas with Alzheimer's, it's the memory that's going to be affected. Motor comes much, much later. Frontal temporal lobe. Who's heard of that one lately? That's our wonderful Bruce Willis has frontal temporal dementia. This is where the front part of the brain, right in this area, has cellular death. And this is where we control our emotions and where we control our impulses. So his wife, I read an article yesterday, and his wife actually said that prior to his diagnosis, she was getting ready to file for divorce because he had become so impulsive and had become so angry about things and just wasn't the man she had married. And then they go to the doctor and find out that he actually has frontal temporal dementia, and she, did not divorce him. She has cared for him very well since then. Yes.
What are the symptoms that one can recognize the
change in behavior? Significant change in behavior. Impulsivity, personality changes, just not the same person they were. It's not going to affect physical very much because it's in the front part that doesn't really control your physical ability, but it's that they're not the person you knew. They're just very different.
I had a friend that had frontal temporal dementia, and their symptom was they forgot how to write.
Oh, okay. Interesting. Yes, ma'am.
Can one person have two different kinds of dementia?
Bottom one, mixed. You can have all of them. You can have all of them. Mild cognitive impairment is just where somebody has some memory, slow memory. It doesn't affect their daily life. They can still take care of themselves. They can still make decisions, but they just have a little bit of a difficult time with some memory issues.
Is that a short-term or long-term?
Usually, that one's usually, all of these pretty much affect short-term first. So short-term.
It's called maturity issues.
Yeah, I was gonna say.
Well, no, we're gonna talk about that in just a minute. We're gonna talk about that in just a minute. Or for this young ladies, you can have multiple. You can have Alzheimer's and still have a brain bleed or blood clot in brain. So you can have multiple dementias, going on at the same time. Yes.
Is mild cognitive impairment a diagnosis in and of itself, or does it go along with other diagnoses?
It is a diagnosis in and of itself, but you go to the doctor and say, I'm just having trouble remembering things like this, but it's not affecting anything. It can, now, what they do say is that NCI can actually be a precursor to Alzheimer's. Not proven yet, but there is that theory that it could be.
When someone has Parkinson's disease, is it definitive that they won't get Alzheimer's?
Oh, no, you mean the Lewy body?
Well, yeah, the
Lewy body. No, not all Parkinson's will get dementia. No, but if a person has Parkinson's and gets dementia, it probably is Lewy body. So, all right, next slide. All right, I hate numbers, so this costs us a lot of money, and it costs us a lot of heartache and tears and hours of care. We have this was back in 2018, so I'd say we've probably got about 7 or 8 million people with Alzheimer's now. By 2050, they anticipate at least 14 million will have Alzheimer's. There's theories, there's still theories, there's no definitive, this causes it, there's nothing that supports that there is a true cause of dementia, of Alzheimer's. That's the sad part, is we still don't know what's causing this to occur.
Cure, cure.
No cure.
I see advertisements, cures dementia.
Wouldn't that be
Which I
nice?
don't believe, but I know.
No.
Yeah, anyway.
And the medications that they give you in the early stage of dementia, like the Aricept and the Namenda and those, are only good during that early stage of dementia. And all they are doing is prolonging the loss of memory. The memory is still going to get lost as the disease progresses. It just prolongs that time. Once the person has reached middle stage, there's really no need to continue to give them the medication because the memory is pretty much impaired, and they're not going to recapture any of that. So doctors tell families all the time, make sure she stays on this for the rest of her life. It doesn't do them any good. There is a point in time where that just needs to stop. All right, so what's going on? You did your anatomy lesson. You didn't know you were going back to school today. So what is going on in the brain? This is a good brain. This is a good cell. So in our brain, here's a brain cell, and here's a brain cell. This is my nucleus, and these are my tendrils. From this brain cell to talk to this brain cell, this one's going to spit out some chemicals, neurotransmitters, and those chemicals are going to go in these little slots down here. So that's how the brain cells talk to each other. If a brain cell can't talk to another brain cell, it will die. So if there's something blocking that neurotransmitter, 2 brain cells are dying at that particular time. So what's happening? There are 2 things going on in the brain of an Alzheimer's patient. One is called plaques. These are protein plaques, and another is called tangles. So if you look at this brain cell, right, or these neurons right here, you see this is a nice clear neuron right here, nucleus, and then you've got nice straight tendrils, looking good. They're going to communicate. They're spitting out chemicals. They're taking them up, and I'm able to say my next word because these brain cells are communicating with each other. If you look over there, you see all that muck? The muck is the plaques. They are called tau, T-A-U, protein, and they accumulate in the brain, and they are preventing this from happening. They also are squishing up, for lack of a better word, squishing up the tendrils here. So if you can look, and I know it's a little hard to see, these tendrils aren't nice and straight. They're all wrinkly. So this one can't talk to this one. So these two brain cells are going to die because they cannot talk to one another. Now, I know this is called protein, and it's an accumulation of protein. It is not from the protein you eat. It is not you and I who are on keto diets. So, it is just protein that we naturally, it naturally occurs in our body, and for some reason the body cannot eliminate that protein sufficiently, so it accumulates in the brain, or it accumulates here. So, next slide. Here is just a graphic of what a healthy brain looks like versus an Alzheimer's brain. As those brain cells die, they literally cause space to occur. So the brain is truly, there is brain damage. So that cellular death, as it continues, will cause brain cells to die. I used to carry this with me when I would go out to see patients, because families have such a hard time understanding why Mama or Daddy or Uncle Joe is acting like they're acting. I can't believe they're being so stubborn. Why are they acting like this? And to show them the picture was quite beneficial for them to really recognize this is just like heart disease or cancer or any other disease. It's a disease. And this person has a very limited ability to control some of the behaviors that they're having. So picture sometimes can speak 1,000 words. So next one. And this is just another little picture of what a good brain looks like versus an Alzheimer's brain. So normal brain, normal aging. So some of us are aging a little bit in here. Some of you will catch up with us. But as we age, there are some things that just do happen naturally. They're just going to happen. I mean, my goodness, our bodies are 60, 70, 80 years old, and they've been through a lot. So we will naturally forget things sometimes. It's just normal. But typically, we can recover that memory. So it's kind of like walking into the kitchen. Walk in the kitchen. So we turn around and we walk back out, and before we get out, oh, that's right, and you hurry back in the kitchen before you forget again. So we have the ability to recall. A person who is developing Alzheimer's may not have the ability to have that recall. They walk in and out of the kitchen a dozen times, if they even think to walk out of the kitchen. They just can't remember why they went in the kitchen. It's much slower, it can be completely lost. I do want to say that before we go any further, a person who has early stage Alzheimer's, this is not every minute of every day. Early stage can be the behavior, the memory loss can be one day they don't remember a thing, and then for the next 2 weeks they're fine. And then they have another day where they can't remember a thing, and then for the next 2 weeks they're fine. Those 2, 3, 4 weeks of time begin to get less and less. And it's now, I can't remember a thing, and now 5 days are fine. And then 4 days are fine. And then by the time you get to middle stage, you're pretty much having difficulty most of the time every day. So just wanted to say that. So when we look at this over here for Alzheimer's development, this isn't every day, all day, in the very early stage. But these are things that families may start to see happening. I hurt my knee back in the spring, and I couldn't walk for several weeks. And now I can't get down on the floor. Just can't do it. So I can't do it because of a physical limitation. I just can't get on the floor anymore. They can't do it because they don't remember how to get on the floor. There's that inability to remember how to do something physical is impaired. We can follow written instructions. We can follow verbal instructions. I can ask Lisa, would you go down the hall and find Ashley and ask her if we could get some more handouts? Lisa would have no problem. She'd go find Ashley and come back. We could ask an Alzheimer's patient that, and they would sit there and go, huh? I do not know. And then the family gets upset. Lisa, did you hear me? I said, get up and go. I need you to go do that, please. So these behaviors over here cause a lot of angst. to our caregivers, to the family, to the loved ones. Also, we need to be very simple with our instructions to an Alzheimer's person. We occasionally forget a date, have been on vacation, and go, oh, I can know what the date is today. You know, that's intentional, it's salvation. But we can reorient ourselves. They do not have the ability to reorient themselves. Next slide. We can have occasional lapse of judgment. You know, when we were teenagers, we don't have lapse of judgments anymore that we are older, but when we were teenagers, you know, we would go out and do the stupid stuff, but we knew what we were doing and we did it anyway. Their lack of judgment is not anything that they're aware of. They're not aware, they're not making good decisions. They're very impulsive. They can do things that are unsafe. And inappropriate. I had a patient one time that I went to visit, and the daughter was Alzheimer, so she was sitting there with a whole stack of papers in front of her, and she was going through bills and everything that Mama had forgotten to pay. However, she found a bill for over $5,000 where Mom had stayed up all night long ordering from QVC. And so it's like, but Mom had no idea she had done that, but she just did it. And then we can abstractly think. Again, thinking to go out of the room, to remember to come back into the room, to remember what we're doing, and they don't have that ability. We lose things from time to time. Just saying, it happens. If I were to lose my phone or not be able to find my phone, the first thing I'm going to do is ask Crystal, would you call my phone? So I'm abstractly thinking, Crystal, call my phone. They don't have that ability to really have that abstract thinking, so the phone's lost. And 9 times out of 10, and I don't think it's up here yet, but 9 times out of 10, they're going to blame somebody else for taking their phone. And we'll talk about that in a minute. But they have no idea that they put the phone somewhere else, that they actually did it. When we cry, or when we laugh, or when we become angry, it is usually related to a specific event or situation. Somebody tells a joke, we laugh. Something hurts us, we cry. They just have spontaneous emotions. It doesn't have any relation to a situation. They may just bust out crying, or they may just start laughing uncontrollably. They may become very angry, and there was no reason for them to become angry. Some small changes in personality. Oftentimes with an Alzheimer's patient at the beginning, they it's kind of with the frontal temporal lobe, their personality becomes a little different than what they were before. So they're not, I'm just a sweet person, and everybody loves me, but then I might become a little bit of a not so sweet person, or and some of that actually is self-preservation. They're trying to hide the fact that they don't want people to recognize that something's wrong. So I'm fine. Just leave me alone. I'm fine. And then slowing down activities because we're just getting older and the bodies are getting worn out. Their slowing down of activities again is that preservation. They don't want you to know that something is wrong. The time frames for the memory losses and the confusion are getting more frequent. And they're afraid you're going to find out, and so they cover it up by, I don't think I'm going to go with you to dinner tonight, because they're afraid of what might happen when they get to the restaurant. They may have an outburst, they may cry, they may laugh, they may get angry, they may throw something, and they don't have any way to control that. So rather than being found out by their family, I'm just going to stay home tonight. I don't think I'll go. Yes.
So they actually recognize that there's something wrong in the beginning stage.
Yes, in the beginning they can, but they can't control when it happens, and they don't realize when it happens what really happens. So anyway, next slide. So want you to take a look at this and kind of remember this. I'm gonna refer back to it, but we're not going to come back to the slide. Early stage is the tangles and plaques are pretty much affected right here on the sides of the brain, right above the ear, and this is where your hippocampus and your amygdala are. There'll be a test on this later. Your hippocampus and your amygdala, and those are the areas that store your memories and control your emotions typically related to memories. So when you have a memory of something that was wonderful, it's the memory plus the amygdala come together to give you that warm feeling of this nice memory. In the middle stage, you can see where this blue is now extending out to different areas. And if you look, it's coming over to this frontal temporal area, which is another reason why you're going to see impulsivity and lack of control of certain things, because it's beginning to affect this part of the brain. And then finally, at the very end stage, it is affecting almost the entire brain. Motor skills, verbal skill, all of those skills are being affected by these plaques and tangles. So next slide. Oh, and can you go back? I don't need you to go back, that's fine. So the heartbreaking thing of this disease is the length of time that somebody has Alzheimer's. So the first stage usually is around 3 to 5 years. We really extended it to a good five years with some of the medications that they can put patients on. The middle stage can be up to 10 to 20 years that this caregiver is living. And then the final stage, or late stage, is usually about 1 to 3 years. So just keeping that in mind. So what's going on in the early stage? Remember now, it's not every day, not all the time. It is infrequent. Yes, ma'am.
Is this why long-term memory, people with Alzheimer's, they have long-time memory?
Oh, I paid her to say that because that's coming next.
Well,
so hang tight, because we're going to talk about that in just a minute.
Okay.
So there, remember, it's happening infrequently at first, and then it starts to happen more and more frequently. So loss of memory, loss of being able to orient themselves to what's going on when they are having one of these bad days. They will use social skills to cover it up, withdraw from social events because you may find out, you tell them you're coming tomorrow morning to take them to the doctor, and you get there the next morning and she's not ready to go to the doctor, and you say, I told you I'd be here at 10 o'clock to take you to the doctor. Oh, I didn't feel good last night, so I didn't sleep good. And that's how they kind of pass it off. They don't want you to know that, oh God, I just totally forgot that we were going to the doctor today. Repetitive stories. If you have ever known anybody with Alzheimer's, they tell the stories over and over and over again. And they ask the question over and over and over again. Caregivers have just got to be okay. You answer the question 50 times if they ask it 50 times. You learn techniques to redirect the question. If they ask, why are we here, why are we here, why are we here? Tell them why you're here, and then start changing the subject or move or take them into another room, and it will change what they're thinking. They're starting to have some problems with activities of daily living. So typically you'll see it first with clothing. They'll just be struggling a little bit more to put their pants on, and they'll maybe put both feet in one leg, and oh, what's going on with this, and get all exasperated, or they button something wrong, but and so I can't get my fingers to work today. So that's how they kind of start out. Paranoia and accusations. So remember the phone I lost a minute ago? Well, Lisa really took it. It was really Lisa. She took it, and I know she did. But they start accusing their family because they don't want to admit that I lost it and I don't know where it is. So you had to have taken it. Loss of spontaneity and initiative, again, back to let's just stay right here. Let's just stay put right here and not move. Poor judgment, personality changes we talked about. They need control. And as I have said many times, my definition of quality of life is my independence. I want to be able to be independent, to do what I need to do, take care of myself as best I can. They have lost their independence. So any little bit of control they can hang on to, they're going to hang on to. So they can be very obstinate when it comes to hanging on to that control. But you'll also find them creating a space. This is my space. This is my chair. These are my things on my table. Don't bother my things. Don't mess with my things. This is my space. And respect their space. because that may be the only control they really have at this point in time. And then this bottom one, I said in the last class, I hope it's not real, finding the right word. That one's not real. I'm taking it off. I am taking that off. It is not real, or either we're all in good company. I do not, I sometimes, and my husband say, he says, how do you teach? So next slide. So, dear diary, it's not so, other people will say, and we've all heard this, we probably all said it ourselves, it's not so bad, I've forgotten things, I forget things all the time. Said, unless you put the frying pan in the freezer, or you put the wallet in the sugar bowl, and wondered how it got there, besides accusing Lisa of it, do you become lost in your own street or your own house? Sometimes they can't even figure out how to get back to their bedroom. They can't remember which way to go. Or do you become confused and fearful 10 times a day without knowing why? Then you don't know Alzheimer's. So we need to recognize, that's where empathy comes in. We need to recognize that they don't have control. And these are things that we will not understand, and I hope and pray you never will understand, because the only way to understand it is to have it. And so we just have to be empathetic to everything. So what does an early stage caregiver need to consider? One is understanding, main thing, understanding. Just understanding that this is a disease. It is not a stubborn, mean-spirited person that just doesn't want to do what you tell them to do, but it's somebody who truly has a disease. When they do get stuck on that word, it is okay to try to help them find the word for a period of time. Don't need to draw that out. If after a couple of, so did you mean this or did you mean that? That can get frustrating if they can't answer you right away, so move on. But it is okay for a couple of times to just ask, did you mean something? Use simple, short, familiar sentences. This class would totally overwhelm somebody with Alzheimer's. They would not be able to, they would just be having a behavior by now. So which goes to prove that y'all are all good right now. Because I don't see any behaviors happening. And we need to give one-step instructions. So fun thing that we do in orientation for our nurses is we have well actually it's for all of our clinical staff. We have a class where they have to make a peanut butter and jelly sandwich. So what we have them do is we have them write down the instructions of how to make a peanut butter and jelly sandwich. And then they give their instructions to one of the presenters, and that presenter has to choose one of the instructions, and then has to make the peanut butter and jelly sandwich based on their instructions. Mm-hmm. How many of you think they can make a peanut butter and jelly sandwich? Not, I don't know that they've ever really made a peanut butter and jelly sandwich. I mean, it's things like, well, put the peanut butter on the bread. What does that mean? Do I take the jar of peanut butter and put it on a loaf of bread? So we just, that peanut butter, put peanut butter on, we know what that means. They don't understand that difficulty, as much as that doesn't seem like difficult, the difficulty of what that means. And we have to think that simply. We have to break things down into very, very simple steps and not ask Lisa to walk out the door, turn to the right, go down the hall, find Ashley, ask for a package, and then come back. That's way too overwhelming for somebody with Alzheimer's. So you have to be very, and this can, I mean, I can't even imagine what it would be like caring for somebody with Alzheimer's when you have to be so deliberate with what you are saying and how you are saying it. That, you know, how dogs and children and other people can read our emotion and all that. Well, Alzheimer's patient can read your emotion and they pick up on it and they respond to however that person is responding. Avoiding using pronouns. That can be very confusing. She's going to the store. Who is she? You know, she could be multiple people. It sounds a little odd sometimes for us to use a proper noun when we're talking in a conversation, but we need to use proper nouns. We need to say, Crystal's going to the store, she's taking Healy with her, and they'll be back later. Not, they are going to the store, because that the person doesn't understand pronouns, so we have to be mindful of using real people's names. I had this happen to me yesterday at work. Somebody was talking to me and said something about Mary didn't do, or Mary was going to do ABC. But prior to Mary doing ABC, we were talking about something that one of the social workers was going to do. So two conversations going on at the same time in 2 sentences. And then she said, so she didn't do it. And I'm like, Mary didn't do it? She says, no, the social worker. And I said, please use names. So even with us, sometimes the conversations can get confusing. Do you know how many slang words we use? And especially coming from Georgia, we got a bunch of slang words. So we have to be mindful that they're not going to understand our slang and our little euphemisms that we use in our particular, area of the country and all. And just willing to repeat yourself over and over and over again, or learning how to redirect, and that is a possibility. And then allow time for responses. Y'all know how much we hate silence? I mean, we have a real problem with silence. So when we ask somebody a question, we expect an answer. We want it right now, because that moment or two of silence is a little uncomfortable. We have to get okay with the silence. They've got to process whatever it was we asked, even if it's yes, no. They've got to process what the answer is going to be in this stage. So, next slide. So now we're going into the middle stage, and you can see the middle stage, the little blue up there, is getting wider. It's going into the frontal lobe now, where things are going to be a little more impulsive and more emotional. So the memory loss here is getting much more severe. So who was it that asked me about the long-term memory? Who did? Okay, so what I want you to do is I want you to think about this hippocampus that we've got here that's storing our memory. Every memory you've ever had since maybe in uterine is stored in the hippocampus. It is like, think of it like a filing cabinet. So in this filing cabinet are all of my memories, and they usually start chronologically now. So the first file in your memory as of right now is going to be this class. Then the next file is yesterday, and the next file is the day before that, and the next file, until you get to toddler, infant. So we're all the way down here. Keep that in mind as we're going through this, because what is happening is as those plaques and tangles start to accumulate in the hippocampus, it is destroying files chronologically backwards. So my memory of this class will go. If you won't remember it. My memory of yesterday will go. And it will chronologically go backwards until you're finally somewhere in this middle stage. That person may be in their 30s, 20s, 30s, 40s in their reality. And that's why there's no sense in trying to get them to reorient to today. It's not happening. So keep that in mind. So memory loss is much more severe. Confusion becomes more prevalent because of this memory loss. They can't remember what's going on, what's happening, so that causes confusion and fear. There's a lot of fear. They have a very short attention span. That's why it's okay if they don't answer your question, just go back later. They're not going to remember that they even had that conversation. Inability to recognize family members. Tough one. This is probably one of the toughest things for caregivers, is when their loved one doesn't know who they are. Again, it's a brain disease. It is a disease. You need to understand that, as hard as that is to understand. So you walk in the room and, okay, I'm a little senior here, and let's just say my mom had Alzheimer's. And I walk in the room and I say, hi, Mom, and she goes, you're not my daughter. Painful, very, very painful. But Mom's Alzheimer's has progressed to where we've eliminated a lot of files. And she's back here in her 30s. How can she have a gray-headed daughter? There's no way, unless I prematurely gray. But there's no way she can have a daughter as old as me. Now, my daughter may very well be or my granddaughter may very well be who she thinks is her daughter, because that would be the appropriate age for her to have a child. So that's what we as nurses have to help our families understand when they are dealing with that. This is where you see a lot of your home health nurses, because we don't typically get patients with Alzheimer's this early. But your home health nurses hopefully understand this and can help families recognize why they're not recognizing them. Yes.
I have a patient now who says what most people think are lies.
Yeah.
How do you address something like that?
Go with it.
She told me she had 2 daughters and 2 sons. She only has 2 daughters. And, you know, like, or she'll say that she did this and that or whatever, but she didn't.
You go with her in her reality. It's her reality.
Okay, but this is normal, I mean, for people to know about every patients, right? They're not lying.
Does she have dementia then? Is it dementia? That's what the first thing is. Does she have a dementia? Because if she has a dementia, there's no reorienting her. That is her reality. So we need to just go with her story.
Okay, well,
So tell me about her.
Yeah, we know that, but dealing with people that
Don't know that.
people, we should take that into consideration.
Yes.
But they're not lying. They're
Yeah.
just, this is what they think.
This is their
This is
reality.
what they remember.
Yeah, it is truly their reality. And it's okay to go with them in their reality. And not try to bringing them into our reality will only cause behavior. Yes, ma'am.
What happens when the brain has, the line goes up, and they'll talk about something right now, and then it closes again?
It's just those, I tell families when they get those periods of time, they're a blessing.
Yeah,
Enjoy them.
I was just wondering if that isn't permanently always,
No, and it'll become less and less
no.
as the disease progresses. They'll become have less time. Yes, sir.
When I'm visiting a patient with dementia or Alzheimer's, as a volunteer, critical of the name tag, we have them all around us, whatever. How important is it to really have it visible, just maybe our first name and the community hospital?
I don't think they'll process the hospice part well. Your name being visible is fine. I am a big believer that we are hospice and it's who we are. We have our name badges and it's what we do, but that's why we took our names and made them much bigger on our name badges now, so that all you really see is our name. So it's fine, it's fine. I don't know has anybody ever asked you what hospice is, a dementia patient? They're probably not going to. They're probably not going to, even if they can read it, to be honest, yes.
As a family member or as a caregiver of somebody, if you're recognizing the early stages, like for example, my grandmother's in her 80s and some of this resonates with me, how can you as a family member advocate for them to get early care?
Just that, advocate that she go to the doctor, and if she's having memory that you want her to, she'll probably start with a primary care doctor, but you need to be just honest with that primary care doctor. Say, this is what we're seeing, and she's going to dispute everything you're saying. She is going to dispute it and say, that is not what's happening, I don't know what she's thinking, and may attack you, not physically, but may attack you as to what are you trying to do. And so you've got to be a little thick-skinned and, have those conversations with the doctors, yes.
I'm a caregiver with my immune system, and I'm with her every single day. She's in a nursing home. And when I work with her, I try to work with her as not perfect. And she does really well. Once you remind her, like, come on, she woke up. Yeah, okay, she woke up. But they're not doing that so far like they need to. And I just wanna, I feel like I'm doing the right thing because she doesn't wanna have, what we call it, an accident. She doesn't want that, you know? but some people say, well, it's it's the dementia, you know?
Well, there will be a point in time where it is.
Right.
And that will be something that is going to do, but as long as she can go when she is triggered to go,
Okay.
I would, again, I encourage independence as long as possible,
That's what I try to do when we here outside also. We just try to keep those independent as we can.
Yeah.
She seems to like that.
Yeah, of course, yeah, because that's, incontinence is
She's
probably one
probably
of
in
the,
that middle stage. It's so confusing, like you say, 1 minute this, and she can laugh at something, that's something that surprised me. You know, I don't know what they can laugh at, yeah, but that's just spontaneity,
yeah. Well, as they get into this stage, I tell families, cherish the moments that they are cognizant, because those times will come less and less.
Since we have, family members who take care of them, I always worry, am I gonna get Alzheimer's? Did I have a brain scan? Which,
Yeah, they can do that APOE genetic testing. It's a genetic, you can, I don't think it's cheap, but you can be genetically tested.
but you can just go to the doctor and say, I have a brain scan.
No.
Would it show you have?
No,
You'll get a referral.
no, you'll get a referral. It's a genetic test. They test your DNA.
Oh,
So
so there's no way.
no, it's kind of like for the breast cancer. If you have breast cancer in your family, they can check for that. So yeah, but no, they're probably not going to do a brain scan like that. So anyway, other things that are going to happen is their language becomes less and less put together. They're going to have sentences where one sentence runs into another sentence and it doesn't make any sense. They have a very difficult time learning anything new, so trying to teach them something can be very frustrating. Social withdrawal, again, that becomes more and more prevalent as the disease progresses. They just don't want to get engaged with anything. Really need assistance now with their clothing, their showering, anything they can do. If you've got to still shower them, or if you've got to now shower them, let them wash their face if they can. Let them do anything that they can do to give them that sense of independence. Because it won't last. There'll be a point in time where you're going to be washing the face too. Hoarding, they love to hoard. Oh my goodness. As long as they're still up and mobile, they are packing things away. If they're in a nursing home, they're going in another patient's room and they're getting stuff out of their room and bringing it to their room. They love to hoard things. You open the drawers and there's all kinds of crackers and candy and clothes and everything. And oh, that's Miss Sally's down the hall, so they love to hoard. But it's again, that's that control. These are my things and don't bother my things. Again, seeing where the blue is migrating to, they're beginning to have more motor issues and less physical ability. And then sundowning. There is still no real explanation for sundowning, but I have a theory, and my theory is that they're tired. End of the day, they've been up all day, they are just plain worn out from the day. And I don't want to equate at all an adult Alzheimer's patient to a toddler, but if you think about the progression backwards, a lot of the behaviors are very similar to that of a toddler, and at the end of the day, what's a toddler do? They are worn out, and they get cranky, and they get irritable, and same thing with an Alzheimer's patient. I thought, man, yes.
Yeah, I was just gonna say, I'm living with somebody who's in the early stages, and what I've noticed is that when she gets tired, we've had a busy morning, busy day, then it's most likely gonna be worse in the afternoon. And I don't think it just has to do with the time of day, it has to do with the physically I'm tired. And one of my friends who is an expert in this area told me that stop and think about how much brain she's using just to be able to continue to do the right things. Her brain is tired.
Yeah.
just from basically remembering how to eat and how to move and how to
Exactly.
do whatever. And so
Exactly.
it's exhausting.
Yeah. So I mean, they're just plain tired, physically, mentally, everything. So, next slide. We've talked about most of these, but they can wander, they can take their clothes off. They're hot. And I've seen them streak down the hallways of nursing homes, completely naked. But they're hot and they don't have any way to tell you they're hot. So what are they gonna do? They're gonna take their clothes off, because they're hot. Wandering, this is scary for families because they can wander out, and there are a few tricks. If you have somebody in the middle stage, is you can put a black mat in front of doorways because their visual perception is off. They don't have the same visual perception that we have, so a black mat in front of the door can look like a hole, and they won't step in it. And then you know how there is such a thing as cellular memory, so they are Houdinis, let me tell you. I think if you put them in handcuffs, they could figure out how to get out of them. So door locks are right here, and we have grown up since we were children undoing door locks. We also have a cellular memory about the latch locks up at the top of the door. Those are common, we know them, they're ingrained in our brain. Put the door lock down at the bottom, the latch down at the bottom. They are not going to bend over to open and lock at the bottom of the door. There's just that perception, that equilibrium is not going to allow them to do that. So you can also put a stop sign on the door. Sometimes you stop because, again, that memory will be there of what a stop sign looks like. So you can put a stop sign on the door. But those are just a couple of tricks that work most of the time. I won't say always, but most of the time. Next slide. Jim has declined greatly in his dementia. Some nights he goes out several times in the middle of the night. I find him around the street near us or next door. He wears pull-ups because he doesn't remember to go to the bathroom, and he doesn't always remember who I am. I keep all the doors locked with keys, and the fence is padlocked shut. The Houdini takes his tools and removes the entire lock when I'm not looking. Yesterday, he disappeared on his bike for 8 hours. He probably rode it 20 miles. The back tire was flat when police found him. That is a real statement of many, many families where their loved ones have just, I don't know, how many silver alerts do we have out all the time? You know, somebody has walked away from the home. And some of the things making gadget boards for them can be very, anything to keep them busy and occupied. So one of the things that a volunteer did for us at a previous hospice I was at is made a masculine fidget board with locks and keys and different things that they could do on this thing. It was really very cool. The baby dolls are because, again, remember she's back in that early stage of her life, and having a child is very comforting. So the baby dolls that you see in a lot of your memory care units can be very comforting to them. So next, late stage. Now late stage is typically when we get a patient on Alzheimer's in hospice. We don't usually get them too much in the middle stage unless they have other things going on too. But that middle stage, that's when all the caregiving is at its most, I don't even know, I mean, that's when caregiving is at its most everything. And that's the period of time that can last 10 to 20 years. I mean, I can't even imagine what a caregiver has lived through for all of those years. So first stage is about 5 years, second is 10 to 20, then stage is about 1 to 3, depending on how healthy they were prior to the dementia. So there is no memory. They have now eliminated all of their files pretty much. The only thing that's really left now is primitive kinds of behaviors, crying out, making noises, the heart beating, the lungs breathing. That's pretty much all that is pretty much left at this point in time. There is no recognition. Before they didn't know who you were, but they thought you were somebody else. Now there's just no recognition. They have lost their language ability. The interesting thing is that there have been some instances, and we won't get to it, but there's slide on your packet that shows a website or a YouTube video. If you get a chance to watch it, it shows where an end-stage Alzheimer's patient actually sings through this lesson. And it's like, oh my, have your tissues ready, because it will cause it. So they are completely independent for everything. There's nothing they're not independent for. Difficulty eating and swallowing can lead to the weight loss, but that's a whole nother topic that I would love to teach to y'all one day, because that one is just like so misunderstood, and people just do not understand the eating and the swallowing. By the time they get to this stage, their ability to remember how to swallow is impaired, and they can actually choke and have a higher risk of pulmonary aspiration. And the body knows how to die. It really does. It knows what to do. And so that's a natural progression to stop eating and drinking. They are at higher risk for infections, and a lot of families will want the antibiotics. That is certainly a family choice, and we will respect whatever a family chooses. My goal would always be, for me personally, would be just make sure I'm comfortable. But you don't need to treat me with an antibiotic. Their physical ability is much more limited now. They get more rigid. It's just bed fast unless you get them out of the bed, physically out of the bed into a chair. And then they're sleeping probably about 20 hours a day. And so total care. So caregiving. I could actually just put 2 words up there. Be present. Just be present. There is, consider, and this is also back in the middle stage, consider the environment. You want to be mindful of what's on TV. Their reality is whatever is happening. And so you've got FBI on and they're shooting and they're banging and all that, and that can be very startling and cause behaviors. A lot of families don't have options to have 2 TVs in different rooms and all that. Get the earphones if you really want to watch FBI and mom's sitting in the room with you and she's in middle or end stage Alzheimer's, so that they're not hearing that. But keeping the environment calm. Using smells. Was this a person who loved to cook and loved to bake and had apple pies going all the time? Have candles going that have that cinnamon smell. I will always believe, and nobody will ever make me believe any different, that the soul and spirit of that person is still there. And we need to respect and speak to that person that was in there before. The brain may be completely damaged from all of the plaques and all, but that person, I will always believe that. So we need to speak to, and when I'm saying speak to, I mean do the things that that person needs to have done for them as a person. We teach our CNAs to know what they did for a living. How many children did they have? What was their favorite color? What were some of their hobbies? So when they're in there doing personal care, they can say, oh, you were a teacher. Wow, I bet you had fun. 3rd grade, boy, that's more, just having conversation with, and I understand that your favorite color was blue, and right now in your room, I see a blue blanket on your bed. I bet you'd love this blue blanket on your bed. So we teach them just to have those conversations. Just being patient and calm. There's not a lot of intervention you can do for a person that's at this stage except be there, just being present. And because we're not feeding and drinking as much, they may take a few bites of some ice cream. Ice cream works. Some ice cream, it's always soothing to the palate, and it's much easier for it to go down. But we need to teach families how to do other things to show their love. Because if you come to my house, I'm going to ask you, hey, what do you want to eat and drink? Because that's how we show each other we love. So, Lisa, may I have your arm a second? Have you get through writing notes? Sure. All right. And is your shoulder okay to go up so they can see your shoulder, the arm? So one thing you don't want to do, and please don't, because I will hit you if you do this to me, is this. Oh, Mama, we love you. Do not do this right. That will aggravate them to no end. Just hold. Just hold. And be very gentle with your hold. And maybe move the hold around a little bit. And, you know, just a little squeeze. None of this stuff. And then maybe just hold a hand. And so this is things that you can do if you're seeing any of our late stage Alzheimer's patients. It's just holding the hand. Take a little lotion and rub. Oh, I had a hand treatment the other day. So, you know, just do a little rubbing of the hand. You don't really need the lotion. Just rub the palm of the hand. Just to be present, just to be there, to show the love. Teaching families how to do a little foot massage, just to hold the foot, maybe rub on the sole a little bit. Because there's not a lot else we can do. Singing's if you have a voice, sing, they would want me to sing, they would be having behaviors, but singing is great. Also, I know that it says use photos, and you go, well, they can't see the photos. You see the photo, and you can describe it. Oh, here's a photo of your son, and it looks like he was hanging out of a tree or something, you know. Just talking about what the photo has and who that is. So just ways to communicate. They're there. They're there. So, quickly, because, oh, y'all gotta go eat lunch. Oh. Okay. Don't ask them, do they remember? Don't ask them if they recognize you. Even in the early stage, you really don't want to start that kind of questioning. Don't use open-ended questions. Use yes/no questions because they can't think of an answer for open-ended questions. Don't use pronouns. Use real people's names. Don't say, I just told you that. That aggravates them to no end. I just told you that. Well, tell them again. So don't use complex sentences. I do want to share real quick the story of 10 years ago. I actually had this happen. I had a patient who I was seeing at a long-term care facility, and her brother had died several years before. I think it was pretty close to the 10 years ago up here. He had died several years before. And all of a sudden she starts asking about him, saying, where's my brother? Well, what do you think the staff at the facility did? Told her he was dead. So every time she would ask, they would tell her, oh, he died about 10 years ago. They couldn't understand why she was having these unusual behaviors. And so we finally figured out that they were constantly repeating to her that he had died. And it's like, come on, people. Every time you tell her that, she goes into an immediate grief response. So she's grieving every time you tell her that. So what do we say? So tell me, what's your brother's name? Oh, it's Dale. Okay. What did Dale do? He worked for the power company. Okay. And what do you want for lunch? So validate the brother. Validate you've heard her ask the question, but then redirect to something else. So we had to have a little session with the staff and teach them how to do that and then probably in a few more weeks she's going to quit asking about it. You know, this was just something in her brain right then. And then forget this one too, because I'm from Georgia. So, that does not count for Georgians. We're going to use those terms. No, actually, that was quite hard for me when I went to nursing school to stop my sweetie and my honey and all that. But no, we don't want to use those. They are disrespectful to an elderly person. I guess. I mean, it doesn't bother me when somebody does that to me. But anyway, we're not going to.
They ask. If it's okay.
If it's okay, then what I've always told nurses to do is, if it's okay with the patient, document it in the record that they have said it is okay or they request it. Then it's their choice. So that's fine. So, I'm not going to go further because y'all got to go have lunch. Okay. Make sure you fill out your evaluation. And I just want to say real quick before you get out of here, thank you. Thank you for everything you do for us. You are an amazing group of people, and we couldn't do what we do without you. So thank you. You're so welcome. I do.
She pushed you down.
Yes, but I can just take your evaluation sheet. Oh, do you need my name on it?
You had a.
Thank you. So you want my name on it then? Actually, no, those are anonymous. And how do I find it? Don't worry about it. Don't worry about it, Miss Kathy.
Well, they have something that doesn't mean those houses. There is a familial component, but, I've got